Tony, thanks. Good evening, everybody. My name is Joe Giratano from Microsoft. I'm a customer success manager for healthcare providers in New York City. So what that means is I talk to providers every day about how to stay successful and innovative using Microsoft products. I'm thrilled to have you. I'm extra thrilled because I think this is the first live speaking event that I've done since COVID. So it is in theme of tonight's event. And what I'm going to take a couple of minutes to do is talk to you guys about what Microsoft Teams is for in general and how providers specifically can capitalize on the technology that we've built, especially considering how we were all forced to be innovative during the pandemic. Now we can capitalize on that innovation post-pandemic and really increase patient care, increase care team collaboration, and all the rest. So when we talk about Microsoft Teams, we talk about it as a platform for all of the other services that you might use. If you're a partner of Microsoft's here today, the services and the systems that you provide to Microsoft surface up and are powered in Teams. If you're a provider or a care coordinator or operations at a hospital, anything like that, your systems of use throughout the day can be surfaced up in Teams. So things like connections to your EHRs or a virtual waiting room, even for virtual health appointments, a digital front door for your patient experience, things for secure messaging like shift-based messaging, dynamic tagging for folks that are on shift or on call. If oncology needs a priority notification, how they get that on the device that they're using on the clinical floors today. Throughout the entire night, what I'd love for you to just keep in mind is, on the Microsoft side of things, meeting customers where they are today. We don't want you to be a full Microsoft shop necessarily overnight. We do want you to connect the dots for you overnight. Things on the care team coordination side, things like shift management, time clocks, EHR in-basket automation. If anyone has ever seen an in-basket from an EHR, it can be cumbersome. So using automation and AI to make that much, much easier for a care team, saving them hours a day of triage for those kinds of messages. Push-a-talk, walkie-talkie kind of things for clinical comms throughout a care floor. And rounding and tumor boards, clinical automation apps. I actually just heard of an amazing app yesterday for hand hygiene monitoring, which actually I didn't realize was so sorely needed, but a provider here in New York just rolled it out to, I think it was their PICU floor, but it was amazing. The way that they could just keep track of it digitally when they were using manual processes to do it before. Like I said, Microsoft Teams is one platform. I'm talking specifically on this slide about virtual health. So things like group classes and group therapy with anonymous join, so that a therapist may be able to see who it is, but other patients don't. We talked about EHR integration, patient to family connection. This was a huge one during the pandemic where patients were stuck in rooms and couldn't see their family. How could we connect them digitally when they weren't able to get visitors? So we used Teams. We had devices like iPads or phones or something in the patient room, and we were able to connect them and stay connected. That's the type of innovation I'm talking about. It was an overnight process. We were forced to do it during the pandemic. How do we take something like that now and capitalize it on it now that we're not forced anymore? The brilliance that came out of this industry during the pandemic was amazing. So I want to try to keep that momentum, especially with the customers I talk to. EHR integration right in Teams. So if you're a care team provider, you're seeing all your patients' information in one pane of glass, the same one that you work in every day and collaborate with the rest of your floor on, the same one that you clock in and out with, and the same one that you share Word documents with and chat with your patients even. So the vision on Microsoft Teams is one pane of glass for all of the things that you need throughout the day, whether it's patient care, care team collaboration, employee collaboration, anything like that, a charge nurse doing shift management, or tasking or approvals, all in one frame. What the idea is that the technology will fade into the background and the services and the processes that you do every day will be upfront. Okay, just like what you're used to from Microsoft, Windows fading in and you using PowerPoint or something else. So I'll end with this. It's just a video quickly of what we are seeing today of Teams using virtual visits using Microsoft Teams. And what I just encourage you to think about while the video is playing, it's a quick 2 minutes, is if your organization or if you're a partner of Microsoft and you have a service that plugs into this, Teams is incredibly modular. So the way that it's showing in the video doesn't necessarily have to be the way that it needs to be in every organization. If you are using a different virtual visit service or something like that, it can plug into Teams seamlessly, and that can power the experience. So take a look. So again, we see it as Teams being the platform that empowers these experiences. So I'll leave it at that. Again, thanks for being here tonight. I'm thrilled to have you at our office. I hope we do many more of these in the future with even larger crowds. But have a great night. And Tony, back to you.
Question?
Oh, sure, yeah.
So first of all, I just experienced my first. They were early. When I was coming, the notes were there. The physician had all my information. Doctors, he'd already reviewed it and done all the information for my in there by the time I got.
I love it.
Pretty cool. So it works. But I have a specific question because I'm in the after the space. I understand how you can do rounds this way. Tumor board is an analysis written but visual, very high resolution. And I can speak louder. I'm not as loud as you. High resolution MRI and
For the recording.
PET.
Yeah.
What?
For the recording.
Okay.
The tumor board.
Often the tumor board discussions are both written, but they revolve around very high resolution MRI, PET CT. It strikes me that if you're remote, it's only as good as the resolution of the computer you're on. Yes. And how do you get around that?
Yeah, good question. And it is. And a lot of so the question for anyone who couldn't hear was, first of all, some kudos for the Teams virtual visit actually working and collecting the information and you being in the patient experience in that scenario, how seamless and easy it is. That's the idea. We don't want people to have to be burdened with paperwork or burdened with getting that information to the right folks. It just shows up. So rounding, yes, is definitely a scenario in Teams that's a little bit more, I think, low to the ground. You can see that working. The tumor board experience, though, is actually app-based. One of our partners created this app, and it was with some guidance from providers. I'm not sure exactly how they get around the resolution piece specifically. I'd imagine it's actually just some zooming on a high-resolution monitor, even something like the Surface Hub that's behind you guys there. Incredibly high resolution, medical grade kind of images can be on there. We can definitely get you the information about how it would work and even customers that are using it today.
Why don't you give your business card? and then we can get some answers out to you. I think that'd be a great idea. Thank you.
Yeah, thanks.
All right, before we continue with moving on our program here, for those people that showed up today, didn't have a chance to officially register, we'd like to make sure that we have all your information in. Where is Mark Russo? Mark? There he is. Can you just stand up, Mark, so everybody can see you? If you haven't registered already, please see Mark, because we want to make sure we have your name and information in. And, you know, also the registration dollars to go into our event here. Okay. All right. So what I'm going to do now is I'm going to ask Susan Matthews, who is the president of the Taylor Matthews Foundation, to come up. And I know, Joe, you have a little video that you're going to show as the start. So. The lavalier is not working, huh? Now it's lit up. It should be.
It's working?
It's working.
Okay.
Okay, Susan. it's all
Thanks,
yours.
Joe. You're already my saving grace. I just met you. Wow, it's wild to speak and see people in person. I know this is a COVID webinar, but it's overwhelming. I'm used to doing Zoom calls. I haven't done an oral presentation in 2.5 years. So bear with me, I have notes. A special thank you to Joe Vitetta, who got me here, and Tony Ferrante, who organized the whole thing, both sitting in the front row. I run the Taylor Matthews Foundation, formerly known as TABANS. TABANS was created by my daughter Taylor when she was diagnosed with cancer at 11 years old. She fought hard, but she lost her battle when she was 16 years old. Just 2 days ago, November 1st, is her birthday. She would have been 31, even though we consider her forever 16. And I have spent the last 15 years of her birthdays at the cemetery. And I don't want that to happen to any other family or any other child. When you have a child that is critically ill with cancer, you always know the importance of every day and every birthday. Even though you know nothing in the world prepares you for a time when they are not there to help. Taylor's mission and my passion to give more children birthdays instead of memorials is what runs my daily life. As painful as this sounds, and I see people's faces going a little, we're talking about childhood cancer. This is a story of hope and inspiration, which began with Taylor and continues with her foundation and the hundreds of people who have heard her story and continue to fund research in her name. We have raised to date about $2 million for pediatric cancer research. We have kept her legacy alive to change the face of pediatric cancer. Taylor always said to me, "Mommy, if I could save the life of one child, it would all be worth it." That's all she wanted, and you'll see her on the video. We have fulfilled her wish, and I know she knows about it. We have fulfilled her wish many times over. So you might ask, where did it all start? Taylor came out of the womb, I'm laughing about her, came out of the room with scratches all over her face. The doctor chuckled, saying that she was clearly impatient and frustrated to get out of the room. Her intensity, impatience, enthusiasm, and energy would be the hallmark of her short life. She played sports, made friends, studied, loved, and laughed in a way that was exhausting and occasionally infuriating. But you couldn't stay angry with her because she always made you laugh. One of her favorite sports was soccer. In the middle of a soccer game, she called out, which was so unusual for her. It was a cold day, and she came over to my husband and I with a tear in her eye and said, "Mommy," she was heaving for breath, "Mommy, I can't breathe," which was so unusual for her. Her pediatrician diagnosed her with exercise-induced asthma, and the inhaler worked. She went back to soccer, she went back to sports. And I said, "I'm just going to take you to a pulmonologist so you can breathe in the box and we'll get the dosing right." For which my pediatrician accused me that I was overreacting, and I always do overreact in medical situations because my mother never went to a doctor. So that's how I was raised. But you can imagine our shock when the pulmonologist took an x-ray and she was completely metastasized to her lungs. That was causing the shortness of breath. Like Taylor, approximately 80% of childhood cancer diagnoses are at an advanced stage. At the time of her diagnosis, we were shocked to find out that the US government dramatically underfunds pediatric cancer research. And pharmaceutical companies do not invest because the numbers are low and the return is not profitable to work on pediatric cancer drugs. The reality was that Taylor's treatment plan included drugs from the 1970s. We were all astounded. We told Taylor, the medicine you're taking is about as old as we are. We were in our 40s. She didn't think that was funny. We tried to make light of it. She took things into her own hands and at 11 years old formed TABANS, which is a 501c3 nonprofit dedicated to raising awareness and funding pediatric cancer research. Now, Joe, so we can get an idea of who Taylor is, let's play it.
Clicker stop working.
Must be an apple cloud.
She's that clapping overwhelms me because I know in heaven she's watching. And I know everyone in this room is continuing her legacy. And that means so much to me. People say to me, is it really hard to do this, to follow? I am so blessed that she left me her legacy, that I can work hard and save a child's life. As a mother with a child lost to cancer, there's nothing better than that. So I'll tell you a little bit more about what went on. She lived for almost 5 years. She suffered brutally during those 5 years. She lost her hair twice, endured dozens of rounds of chemotherapy, intense radiation, and 14 surgeries. Before surgery, my husband always had to take her into the OR because I couldn't control myself. I would cry every time. And she said, "Don't cry, Mommy. This is a good thing. They're taking cancer out of my body." Well, full knowing that she was going to come out in intense pain and most likely on a respirator. But with her, it was like, get it done, and I'm going out with my friends. What that does, seeing all that pain and suffering, what that does to a mother is unimaginable. But if Taylor were here today, she would tell you she didn't suffer. Childhood cancer occurs regularly, randomly, and spares no ethnic group, socioeconomic class, or geographic reason. Cancer is the #1 cause of death by disease in children. Approximately 17,000 children will be diagnosed in the United States each year, and that number worldwide is $300,000. I'm thinking dollar signs. 300,000 kids. 45,000 children are in treatment in any given year. Our children are losing the battle, and the U.S. government is not doing anything about it. The National Cancer Institute only allocates 4% of their budget to all pediatric cancers. And you wouldn't think it, but there are hundreds of them. And the treatments, current treatments, are so toxic that 2/3 of childhood cancer survivors will have long, dire complications, including additional cancers caused by treatment and a shortened life span. Our goal has been and always will be to help children with cancer by funding cutting-edge research that can impact their lives now, not years and miles of bureaucratic red tape, because today is the only day a child with cancer has. Let me give you an example of the difference that small donations can make. We funded a study, this is a mouthful, for demoplastic small round cell tumor at Memorial Sloan Kettering. This is a rare tumor that attacks adolescents in their abdomen. Instead of spreading to other places in the body, which is what we usually think when cancer metastasizes, it's in the abdomen and it causes all little tumors on all of your internal organs. The survival rate for this is 15% for 5 years. And I don't know if you know, but Taylor lived 4 years, 8 months. If she lived another 4 months, she would have been considered a survivor. So the pediatric cancer rate that they say is 80% survivable is only at the 5-year mark. And I mean, how she would have been filled with cancer and considered a survivor if she just lasted another 4 months is crazy. So you really can't listen to the numbers. But in this study, you may already know that cancer research has changed its focus in recent years. Rather than developing drugs that address cancer based upon how they grow, they focus on the receptors on the outside of cells. What's exciting is that it's possible that existing drugs for one cancer may very well help another cancer. Sloan invented a drug some years ago for a killer cancer that affected children's nerve tissue. They noticed that, I'll just call it demoplastic tumor, instead of saying all the words, had remarkably similar receptors at the nerve cancer as the nerve cancer. They proved the drug could kill in petri dishes. They proved it could kill the tumor in mice. But when they put it in kids, nothing happened. And they surmised that by giving it IV, it had to be processed through your liver and kidneys. And by the time they got to the abdomen, which does not have much blood supply, the dosing wasn't right. So the study we funded was in surgery to take out the tumor, which was standard protocol at the time and could extend life. It was not curative, but could extend life. Excuse me. They put in a catheter of this antibody that Sloan had invented, going right to the site. And doing that, we funded the study in the beginning. We funded 10 kids. In the original results, 6 children had no evidence of cancer, and several others saw no progression. These children are having birthdays instead of memorials. And it only costs, what would you think it costs to fund that trial? No one's going to raise their hand. $150,000. That's it. So small donations go a long way. Another trial that we funded was comprehensive genetic sequencing at Columbia University Medical Center, which enables personalized treatment for individual patients. They've been doing this a long time with adults, but they aggressively just started with kids about 7 years ago. Of the patients sequenced, 71% had clinically impactful finding results in diagnostic confirmation and treatment protocols that would not otherwise have been identified. Mutations, DNA mutations that they found can be treated with currently available drugs in 41% of the population. Customized treatments targeting the precise characteristics of a child's tumor is groundbreaking than how it was normally treated, one size fits all. And the cost to sequence an entire genome of the child is $5,000. With $5,000, you can save a life. And that is mostly not covered by insurance. And Columbia is on 168th Street, which caters to an underprivileged population that is on Medicaid, many patients, and they cover none of it. So since 2014, we have funded every child in the tri-state area. And Columbia has another foundation that funds children that come into Columbia just to get sequenced and live in other parts of the world or other parts of the country. While we have funded Columbia over $1 million to date, never any year was our donation greater than $100,000. So that $100,000 covered getting all kids in the tri-state area sequenced, which led to new protocols and ultimate survival. What makes the Taylor Matthews Foundation different is we run very lean. Almost 100% of our monies raised go directly to cancer. We have no paid employees. We all work in our offices. When we fund grants to scientists and researchers, we speculate by contract that they will not use any of our funds for administrative costs. Even a National Institute of Health grant, the hospital or the researchers are allowed to use 80% of the money for administration costs. We won't do that. I'm not paying for the floors to be mopped in the lab. I'm paying for strict research. We will not fund any trials where a placebo is part of the trial, and we only fund research protocols where the child receives benefit today. We have granted funds to Columbia Medical University, Memorial Sloan Kettering, the Very Rare Cancer Consortium, which is in New York, MD Anderson Cancer Center, the Pediatric Brain Tumor Foundation, and the National Institute of Health, which you might think is crazy that we're funding the government, but they need private philanthropy to continue their work. So in conclusion, Taylor came into our lives and left way too quickly. The short 16 years were filled with bliss, laughter, and love. She taught us all to live in the moment, which I think we all know about COVID and so many people lost. It wasn't just the pain she endured or the fearless approach she took to the risks and the toll of treatments that we asked her to accept. It was her never flagging insistence that she would live life on her terms and press the envelope at every turn, find the next solution, find the next idea. She always had a reason to be happy, a reason to laugh, a reason to love, and a reason to live. She truly believed in life that all you needed was love. A mother holds her daughter's hand for a little while, but her heart forever. Taylor's life was not only about what she accomplished, but also what she left behind. Her boundless optimism at the bleakest moments, her concern for others even when she was at her worst, and her zest for life even as she was approaching death, taught me more about love than I thought there was to know. She actually passed away when we were in Germany doing a trial that had not been approved in the United States at the time, which is now that. And she was on a respirator. It was her last days. She actually passed away 2 days later. And she said to me, Mommy, am I getting back for Joanna's Sweet 16 next week? She fully thought she was going to the Sweet 16 next week and living life. Nothing ever got her down. While her life was tragically cut short, her mark on the world lives in our family, in the organization, and in children who have won and will win their battle against cancer. Thank you for letting me share Taylor's story and her mission.
Wow. That's all I can say right now. Susan, thank you very much for sharing your story and bringing it to us today. And I want to take another second to thank everybody in this room, because the little bit of money that we collected today is going to go a long way to helping somebody else. So here we are in healthcare. We're providing not only education, but helping others that in need. Thank you, and thank you all. I appreciate it. So, Joe, can you get that mic to Dr. Beverley, the one on the chair? Okay, now we're going to get to the meat and the heart of the presentation that we wanted to do, which is about COVID before, during, and after. Dr. Beverley. Okay. And our moderator has taken this to heart and decided to get COVID. Okay, so that's why she is remote. And I wasn't sure if I saw a mask on her face or not, because I just want to make sure that we're all safe here today, even though only
I have one right here.
Kathleen McGrow is on the other end over here. I guess once we get the monitor back, we can all see her. Yeah, I can see her up here on the screen. So I'm going to turn it over to Kathleen, who will take a moment and introduce each of our panelists, and then go through the Q&A. After that, we will be carrying a mic around. So if anybody has any questions, we're going to ask you to raise your hand. Wait till we come over to you. We'll give you the mic, and you can ask the question of our panelist here. There she is, Kathleen COVID McGrow. Thank you.
I never used this before. I don't know.
Thanks, Tony. Thank you, everyone. Can you hear me okay?
Yes.
Perfect. I am very sorry that I'm not there in person. I was so looking forward to this event for the last 6 weeks that we've been planning it, actually. I'm Dr. Kathleen McGrow. I'm the Chief Nursing Information Officer for Microsoft US Health and Life Sciences. And I would like to welcome everyone to today's panel, COVID Before, During, and After, a healthcare system-wide perspective. I'd also like to do a special thank you, shout out to the New York HIMSS, HFMA of Metro New York, and HEC. We're very excited to partner with these organizations and bring you this presentation. And special thank you to Tony for kind of rolling it with it when I let him know I had COVID. I do want to let you know I'm a nurse. I'm a very good masker and hand washer. And I did go to a customer site last week where believe it or not, in that state, the hospitals are optional with their masking. Although my team, we all wore our mask. Obviously, we couldn't dodge the bullet, unfortunately. So I'm very excited to see all of you there in person, and I really wish that I could be there with you, and especially the panelists, because we've spoken a few times, and I would love to have met them in person. The irony that today's session is titled COVID Before, During, and After, a Healthcare System-Wide Perspective is not lost to me as I sit here in home isolation after contracting COVID. So I'm so impressed with this varied experience of our thought leaders that we have on stage today. What I'd like to do is start with some introductions and have them introduce themselves and their organizations, and then we'll get started with our Q&A. And if we have time at the end, we'll open it up to the floor if folks would like to ask questions. So we'll go ahead and start. We can go ahead and start. We'll go left to right. So Dr. Julie Luengas, Julie, if you want to go ahead and start, and then you can just pass it down the row.
Hi, I'm Julie Luengas. I have my doctorate in nursing. I'm the Chief Nursing Informatics Officer at Stony Brook Medicine on Long Island. We're about 50 miles east of here.
Hi, good evening. My name is Leo Bodden. I'm the Chief Digital and Technology Officer for New York Presbyterian. I actually began my career at Columbia Presbyterian 27 years ago. So your story hit home.
Hi, good evening all. My name is Dr. Mauvareen Beverley. I'm president of Mauvareen Beverley, MD PLLC, Patient Engagement and Cultural Competence. I'm a consultant and I started my company in 2019 and I've done various presentations at different institutions, including Northwell, Medical Society of the State of New York. And I was honored to be chosen to do a presentation at Touro Medical College in Manhattan last week. And so I just want to say I'm honored to be on this amazing panel. And Kathleen, I wish you well, and I hope everything goes well. And just a thank you to Dennis Coleman and also to Marsha Thomas Brown, for chairman of the committee. And just thank you for inviting me. Much appreciated. Thank you.
It'd be good if you had the mic. Yeah, if you don't, I just,
Oh yeah, this would be definitely better. Do I need to take all this off? Thank you. Can you hear me?
Yes, I can hear you. Can everyone else hear in the room?
Can you hear me?
Hello? Okay, there we go. Hi, good evening, everybody, and thank you for inviting me as well. I appreciate being the opportunity to be here with this panel. My name is Sean Smith. I am the CFO at the University Hospital of Downstate. I guess I would say we are the only state-operated academic medical center in the borough of Brooklyn. We we serve a diverse, culturally diverse, and medically, I would say, medically underserved population in Brooklyn. Primary working class, low income, with unfavorable social drivers in health, with even worse health outcomes. We're considered a safety net hospital, and I have a 80% governmental payer mix.
Thank you, Sean. Thank you, Sean. So, Julie, we're going to start with you. We'll just go across the row, and I'd like this to be conversational, and I can actually see all of you. So if I see someone trying to make a move with the mic that they're going to speak, I'll try not to step on you. It's a little bit touchy, given that I'm the remote and I'm the facilitator, but I know we got this. We can do it. We're used to this technology now. So, Julie, I just wanted to talk about when we were preparing for the panel today, you had mentioned that you felt agility was key to your organizational shift during COVID. And I was just wondering if you could kind of talk a little bit about, why do you believe your organization is agile, and how do you believe it helped? And if there were some examples that you might have.
Sure, I'd like to share a couple examples. One of them was we looked at the burden of nursing with the number of patients that we had in the acuity level. So we implemented rapid design and we streamlined the admission history documentation. And as a result, we put some guiding principles forward. And we did this over a 3-week time period, which normally would have taken 6 months to get everybody on board with it. But our guiding principles was it had to add value to taking care of the patient, a regulatory requirement, and it wasn't being captured or documented anywhere else. And those were our guiding principles. As a result, we removed a total of 14 sections and 90 questions from the admission history of information that wasn't adding value, but everyone was being required to ask it and look at it, which is a lot of busyness. And it saved the nurses on average around 20 minutes to collect an admission history. One of the things, and it just happens to be, we are at Microsoft, but I'm really proud about this, and it wasn't planned, but we were doing 5 telehealth visits a day. With COVID, within 3 weeks, it went up to 1,300 visits a day, utilizing Microsoft Teams. And I just wanted to shout out, this was spearheaded really by 2 people from IT, our CIO, Dr. Jerry Kelly, a senior project manager, Joan Crawford, in collaboration with our clinicians. It took those groups, but they led it and made it happen. 1,300 visits within 3 weeks from 5. It's phenomenal. Another thing I want to talk about is what our nurses did. So the issues that you heard with PPE and the shortages, that was real. And we wanted to be in the room with our patients. That's what we do as nurses. We're with them, we listen to them, we take care of them. But when you have a shortage of PPE, you have to think about how often are you going into a room to protect yourself and your other patients and your family. They also thought about isolationism. How is it for that family and that patient? The family knows my patients, my family members in there. No one's in the room. You go in the room as little as possible because you have to conserve that PPE. And the nurses, as nurses did across the country, were very innovative. They started putting pictures of themselves on their uniform so that patient could see them and know who they were and have a face to interact with, because that really makes a difference.
Yeah, I agree, Julie. I love that personal touch. That's really nice. As a critical care nurse who wore a lot of PPE, working in a trauma unit, I think that was something that we should have probably even done back then. Thanks for the shout out to teams. I'm sure Joe G is like really jumping up and down. That's very exciting. I was not aware of that. This was not planned, so that was very nice shout out. Thank you. I love the fact that you talk about this decrease of documentation. For folks on the audience, JAMA did release an article last week, I believe it was the week prior, that there was a article released that 50% of documentation is duplicated. And does it really tell the story of your patient when you have that much duplication? So phenomenal. And I agree, crisis is a catalyst for innovation. So you had to do it really quickly. And it's really exciting to hear the types of things and how you were agile. So very exciting. I'm going to move on to Leo. Leo, you said that your organization, being at the epicenter of the pandemic, there was really significant impact for COVID, and that you had to manage. What were some of those implications that you found, being as you were kind of on the hot seat right away almost?
Sure. Thanks so much. Yeah, we were essentially the epic. I'm sorry, the COVID hospital for New York, and New York was the COVID state for the United States. In hindsight, if you would have asked me this as things were going on, I would have never said this. But in hindsight, I think that was the best thing that could have happened for the U.S. And the reason is COVID came in through the richest state in the nation, and then it hit a hospital that's fairly well funded. So we're very fortunate to be able to respond fairly quickly. Now, for us, we did question the data in the beginning. We were tracking everything that was happening in China. We were tracking everything that was happening in Italy, and never did we believe that that could have happened here in the United States. And so for the first couple of weeks, we kept saying, no, 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 that won't happen. It wasn't until a Saturday morning, we were having daily meetings for the entire senior leadership team of the organization and key members of our operations and clinical teams. It wasn't until a Saturday morning when we're reviewing the events of the previous day. Now, at this point, second week, we've already had a few patients in-house for a couple of weeks. And they're talking about one individual, 39 years old, who, as everything seemed okay in the middle of a conversation, just crashed. This individual looked healthy, everything seemed fine, and they couldn't recover. Our COO, who was involved in the response, said what was described looked exactly like what happened in China, what she had heard from her colleagues in China, what she had heard from her colleagues in Italy. And at that point, you could hear a pin drop. We realized we need to move very, very quickly to make sure that our clinical teams don't find themselves having to make the very difficult decisions that our colleagues in China, our colleagues in Italy had to make. In other words, you come into a hospital, there aren't enough resources. And if you are 70 years old, you die. If you're 55 years old, you live. And those were very difficult decisions that those clinicians had to make, which we wanted to make sure that our clinicians never had to.
Yeah, that's a very difficult position to be having to triage patients like that. And you brought it right back fresh into my memory, because I remember hearing about these patients that came in and they were awake and talking, and then before you knew it, the clinicians were saying they were just crashing. And then a lot of the treatments, like early intubation, we learned later down the road now that wasn't necessarily a good thing. So because we just didn't know what we didn't know, right, as clinical to do interventions.
Kathleen, sorry, if you
Sure.
before you keep going, because that's a very important point. We also need to recognize that what we know today in hindsight, we think of the things that we did back then as dumb, stupid. I mean, Bob, you and I were talking about some of the things that we're still hearing. And so when we look out, 5 years from now, 10 years from now, and we look back, we'll know, treatments weren't correct. Maybe even the vaccines weren't completely as effective as we would have wanted them to. Looking in hindsight now, being 2020, it's very easy to question some of the mistakes that we made based on ignorance. But I do want to recognize just New York in general, New York State, New York City, and certainly my organization for the way they've responded with the lack of information and the lack of treatments at the time.
Yeah, that's a good shout out, Lito. Thanks very much for bringing that to the forefront of our attention, because that's very important to recognize. You really did lead the charge and suffered early on for all the rest of our states.
I'll just
Go ahead, Sean.
beg to differ a little bit in sense of being the epicenter. Our hospital at Downstate was designated a COVID-only hospital by former Governor Mario Cuomo at that time, and we were scrambling. We didn't know what to do in sense of this COVID virus, how it was going to affect people. We didn't have the proper PPE, the isolation rooms. We were using plastic to basically drape the rooms to create. We have an old facility, so trying to separate and isolate those individuals that were coming in with COVID was a real challenge for our nursing staff, and kudos to them and our physicians. But I tell you, it's really amazing how we've come from where we were. And I believe what Leo said, that we'll probably look back and look at the mistakes we did make, but we were prepared for the next pandemic that comes.
Agree, 100%. So Dr. Beverley, I wanted to talk to you just a minute because you've done some great work, especially around health equity, including information about my home state of Maryland, because we saw a huge problem with our vaccine uptake and just, getting to our marginalized populations. It's a big problem. I'm from the Baltimore area, and I've worked clinically most of my entire career in Baltimore City institutions. Can you please just talk a little bit about how you saw COVID impact the health disparities that we already knew we had?
Yes, I think COVID has shed a bright light on health disparities. Pre-COVID, during COVID, and hopefully as we are able to solve the COVID problem by whatever year, we will be talking about health equity as opposed to health disparities. And so let's look at it from the perception reality lens. So the perception is, and I just want to also point out the disparities against all minority populations, but particularly among African Americans who have the highest death rate. So the perception is that people contracted COVID because of their socioeconomic status, low income, in poverty, lack of access to care, transportation issues, and what I realized that it's a perception, particularly of the Black population. So let's look at the reality. As you mentioned, Prince George County in Maryland, one of the highly a high level economic community. High Black community, one of the highest income community, Black community across the nation. They had the highest COVID death rate. When you look in Brooklyn, New York, where there are 3 public hospitals, Kings County, Coney Island, Woodhull, as mentioned, a large state hospital, and probably another 7 or 8 private hospitals. So access to care and transportation was not the issue, because you don't need an insurance to go to public hospitals, including Downstate. Transportation runs through Black and white Brooklyn, if I could say that. It runs through all aspects of Brooklyn, but the Black population in Brooklyn had the highest COVID death rate. The individuals who died on the subway system had nothing to do with social determinants of health or poverty. They had a salary of about 50 to 60,000. They had pensions, they had health plans. Probably the reason why they died, and 50 of the 60 who died were African Americans. And probably the reason why they died is because in the beginning of COVID, where there was not we didn't fully understand the ramifications and the consequences of COVID, they died probably because they came in contact with 1 million people on the subway system, at that point. So I just want to read a statement from a professor. So her name is Tangela Purnell. She's Associate Director at Johns Hopkins Center for Health Equity. She said, we see a stark racial disparity even at the high income levels. People say, oh, minorities are dying because they're poor. We know that's not the case. And I think if we buy into the perception as opposed to the reality, and you create a system based on the perception, it's going to fail. But if the perception and the reality is the same, good, bad, happy, or sad, institutions have an opportunity to collaborate with patients and family and communities as well. So first, we have to look at our perception of the community, and part of that perception is how we perceive the African American community. And I think this change starts there to heighten the human value. Thank you.
Thank you,
I'd
Dr.
just
Beverley.
like
Go
to
ahead.
add to that. I think because I work in Brooklyn at SUNY Downstate, and the other issue I believe, we talk about social determinants of health, but I think the African American community, and I have a Black Caribbean community, is that they also are much sicker, right? So they're I guess have more comorbidities, and if they are exposed to a virus like this, their chances of getting sick are greater.
Well, I will discuss that with the Caribbean and African American community on my next question in terms of cultural competence.
Sorry, I didn't want to jump ahead.
That's okay.
Yes, yes.
Dr. Beverley, you can address it now if you would like. That's fine. Totally fine. Yeah, we can go off script here. We're
Okay,
fine.
So my background, my family's from Jamaica, and I grew up here since I was 10 years old. So I'm not going to tell you how old I am now. So my life was spent in the United States. I grew up in Brooklyn, down Bronx, South Bronx, and moved to the East Bronx, and I went to Boston University and did my medical degree at University of Buffalo State of Medicine. University of Buffalo, and I trained at Harlem Hospital, Columbia Presbyterian. Back in those days, at Harlem Hospital, under the leadership of Dr. Thompson, we were never expected to treat any patient different, regardless whether you were a drug addict or a churchgoer. Everybody was entitled to excellent care, and there is a thing that's embedded in our brain: get the patient well by morning report. And we didn't segregate out the drug addicts from the churchgoers. And fast forward, I just want to say, 40 years later, we had a reunion, and everybody came from north, south, east, and west to honor Dr. Thompson. So where have you seen that before? And that time we were Afro-wearing Black resident and Vietnam protesting white residents. And that was the team. So in terms of cultural competence and understanding, it's important to understand in Brooklyn, the Caribbean population, and I was at Kings County in charge of congestive heart failure readmission prevention, when Medicare came out and said, if you get readmitted within 30 days, we'll only pay for one admission. And each institution across the country was responsible to decrease that, if for no other reason but financial. And as I stated, Brooklyn had a large Caribbean population. The top islands were Jamaica, Trinidad, Haiti, and Guyana. And interestingly, 95% of the cohort of African Americans came from the Carolinas. And so part of cultural competence, you have to understand the history. So I'm saying, why is everybody from the Carolinas? Virginia is sort of down the street from us. Why not? We don't have anybody from Virginia. But it's cultural competence is so important. History is after the Emancipation Proclamation, when Blacks had their first representation in Congress, their communities started to do better than the white communities. It's like a mini Tulsa. They built schools, they built churches, they built businesses. The plantation property owner went south because nobody was picking, the damn cotton. Nobody was picking that anymore. And over the course of time, the Ku Klux Klan came in and burned the place down, and they came up the coastline to New York. And it's important to understand that because, and there's even a documentary if you want to look at the Wilmington Massacre. And this went up and they migrated from the South up until 1965. Okay, so cultural competence, if you don't know that, and so when an elderly Black person in the hospital says my parents were a step away from slavery and my grandparents were slaves, who understands that concept? Who understands that? And these are, as far as I'm concerned, atrocity survivors. And the role of religion in this population was pivotal to their survival. And it's not, they are not a part of the cultural competence conversation. And they have the worst health outcomes. And when you think of the atrocity that they endured, it should never happen. And health systems have to look at that population. And because they're dying more than COVID than anybody else.
Thank you, Dr. Beverley. I
I'm
appreciate
sorry, just
that.
tell me.
No, I
And I just
appreciate
want
that.
to add to this is that as this was occurring, we had to go through an exercise of unconscious bias, right, with our physicians, right? You said there's a perception out there, right? And that there's an unconscious bias that we realized within our own faculty that they didn't realize it, you know, and brought out as the African community, African American community was speaking out and saying, what's going on here? Why are we dying, right? And why are we not getting the care that we need?
So, Sean, I'm going to switch gears just a minute and have you put on your CFO hat and just talk about, you know, the impacts that you saw from COVID around the issues, especially around labor, and then the cost and other impacts.
Yes. So just put in perspective, pre-COVID, I had about 11,000 discharges and about 279,000 outpatient visits pre-COVID. During COVID, when we designated a COVID hospital by the former Governor Mario Cuomo, we saw that all outpatient volume went out the door, right? We had a discharge outpatient population because we're now only accepting COVID only patients. So my volumes dropped, but the cost of labor started to move upward, as everybody knows, right? So now people were calling out sick during COVID because they were afraid. They didn't want to come to work. They didn't know what to expect. So we had to rely on agency utilization. We always used agency utilization pre-COVID. My number was about 6 million to cover gaps in staffing. During COVID, that number went to about 12 million. It doubled. So we had to basically scramble. We were trying to fill gaps in staffing, utilizing nursing agency. Even the ancillary services, respiratory techs, laboratory techs, we use an agency to fill those gaps. It was just amazing the amount of, I guess, during COVID, this people being scared, not wanting to come to work, the cost of supplies, the PP&P issue, right? Relying on, I guess, utilizing, you're talking about supplies and other costs. We were recycling our PPE equipment. We were receiving donations, thankfully. But those costs going through the roof as supply chain shortages were happening. We're still feeling that effect now. As you're aware, we used to say we're fighting for the same patients. Now we're fighting for the same employees. Right? The market is tightened. Inflation has, I think it's around 9% now. So the cost of living's going up. There's a ripple effect that's going on. Supply chain issues, as you're aware, the disruption. So labor cost makes up about 50% of my total operating cost. The other 27% comes out of my supply cost. And those are the two areas where I'm trying to manage, right? I'm trying to control overtime, bring that down if we can. Retain employees. So we're trying to be competitive in the market as the great resignation has occurred. People are leaving healthcare. They don't, they're retiring early. And like I said, people are getting out of the industry and don't want to be in healthcare. So we're all, I think every healthcare system struggling to have enough staff and to retain staff. So it's a very competitive market and it's just driving cost up. And
Yeah.
we're predicting, I think, a 7% increase in salaries, about another 15% increase in supplies and other, and pharmaceuticals in that bucket. So it's really challenging now.
That's amazing. Julie, I wanted to kind of switch gears and coming back to you, a little bit of hanging on to what Sean was talking about, because you talked about some phenomenal initiatives, and I'm sure you're highly sensitive to the nursing crisis that we have right now, the shortage. Talked to a chief nursing officer just last week, and not in the New York area, but I was shocked and appalled when she told me that her 70% of her staff for her many hospital system is 0 to 3 years experience. 0 to 3 years experience. So that's frightful. I'm sure you're seeing very similar. Maybe New York not quite as bad, but it's really, there's a dearth of seasoned nurses that are out there. How do you see the initiative? So, and I believe that things like automation, artificial intelligence, technology is, we can't produce more nurses or more people all of a sudden, or even more support staff. How do you see the strategies that you've kind of put into place during COVID kind of pulling through and helping you move forward? Or are there some other things that you may be working on that you see for the future to help your organization?
Sure, we can definitely take the lessons learned of the changes that we made, whether they were human or technology, with the future. So for example, I'll just take one. So we also led vaccine pods, and giving a plug here, we did use Microsoft bookings. But what we, I'm
Hey,
not getting any money for this. But
didn't know that. We got to talk, Julie.
But here's the thing, one of the things we learned from those vaccine pods, when monkeypox came around, we were able to take the lessons learned from our COVID pods and immediately put that into place and stand up our monkeypox pods immediately. From the nursing, bless you, from the nursing perspective, absolutely. The expert nurses, many of them have retired. We are also a state university system. I'm one of the top 100 for US News World and Report. Very proud of that. But we also see the expertise leaving. So we have a large population of novice nurses. And also there's a lot of competition. This is not a very big area. There's a lot of hospitals. So then you have hospitals, because we all are desperate to get great nurses, that will offer you $10,000 to come, you $5,000, or the travel nurses. So we're losing expertise and we're getting novice nurses in. And we have an incredible training program that's been recognized for orientation for nurses. So where our new nurses are within a year, they're at a different level of expertise than other nurses are for a year. And that makes them very attractive to other organizations. So we have to figure out, how do we retain them? And what do we do? And as we have the burden of documentation, the burden of acuity level, volume, and we're seeing a huge volume again, as with what's going on with respiratory across the country, we're seeing it in our site as well. We have to be creative about how we can ensure that we have the tools that they need and we're streamlining it. So we're looking at other ways that we can reduce documentation that also makes them feel that they're meeting the legal requirements, because that's the other piece. If I didn't document it, there's a feeling of, if there's a legal suit, I'm going to be sued. I'm going to lose my job, the organization. So we did things, for example, that once you do your first head to toe assessment, subsequently later, if nothing's changed, I can document nothing's changed from the prior assessment, or nothing's changed for the prior assessment except for, and go look at those exceptions. So they feel like at least I documented something and people know I'm actually taking care of the patient. We've also looked at our standards of care. There's this mindset that if I turn the patient every 2 hours and I document it, this is really phenomenal. So the amount of time that I'm spending telling in the record, I turn the patient Q2, 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 times 8 patients for 12 hours, that's a lot of time. We can see from the outcomes whether or not I turn that patient. and whether or not they have a skin injury or not. So we did things to help them feel better, and we took several of our standards of care. And instead of making them document these things every 2 hours or every 1 hour, we're letting them at the end of the shift say standards of care met or standards of care not met. And here's the reason why. Maybe the patient was off the unit for several hours. And what's that letting the nurses do is be back at the bedside.
I
And
love
have
that.
time and not spending on non-value added activities. Another thing that we're talking about, and I think this is something that's a buzz in the industry right now, is virtual nursing.
Hmm.
And what that means is how can we look at bringing that expertise to perhaps I have the expertise, but I'm physically not able to be on the unit 12 hours a day doing that, direct patient care. But perhaps I can be an expert nurse and I'm looking at the records of the patients on the unit. I'm physically looking at them if we have cameras, and I can coach those novice nurses and be a guide for them and coach them and give them a sounding board. This is what I'm thinking, and help them lead and say, well, have you considered this? I'm kind of seeing these changes. And then other pieces, and in fact, two of my team members in the room, Rosa and Christina, they've been working a lot on doing clinical decision support. We can call it AI, but it's really not AI because we're the ones creating the intelligence. But for example, we were looking at, we had patients that when we first test them, they're negative for COVID. But then a couple of days later, they might have a little increase in temperature, a little increase in respiratory rate, these really minute symptoms. But if you put them all together, it's like, oh, maybe I should test this patient. But trying to catch that with the 1,000 of data elements that we're collecting on each patient every shift is really difficult. So they work together with our clinical teams to develop algorithms that is going to look across the system and say, wait a minute, Julie's temperature went up. And oh, by the way, an hour ago, her respiratory rate went up. She does not have a COVID test pending and or a negative COVID test in the last 24 hours. We're going to go ahead and put a COVID test, order it automatically. And we found that it's been really successful, and a lot of patients are coming up positive, which means not a good thing for the patient, but we can immediately make sure we have the right PPE for the staff taking care of them, ensure that they need to be in a private room. We can get them in a private room. And these are things that we can help. But, I think as an industry, we are responsible for many things. One, we need to push back on some of the regulatory agencies and focus on outcomes. There's many things for certifications that require us to document, for example, 50 elements, but our outcomes can say, are we really meeting those certifications? Because the key is really to have us at the bedside. The other component is how are we looking at our patients when they go home and looking at what are the services that they need, and can we do virtual nursing with them as well and take care of those opportunities, because that may reduce readmissions. And having that nurse look in when you have that patient who's gone home from surgery, we may call them, how are you doing? But boy, if we could look at them and look at the wound and see what's happening in that home, we might recognize we need to send somebody out now or have them come into the clinic and not wait that week to 10 days for a follow-up visit.
Wow, there was so much goodness in everything that you talked about there. I could totally see how you could potentially make that CDS AI by trying to predict which patients would need to be tested, and putting them in that queue for that testing. And then the opportunity for virtual nursing for your seasoned nurses, your more experienced, I call them nurses. It gives them an avenue. Maybe they don't want to leave nursing, but they're just the bedside just worn them down over COVID times. And so those are just phenomenal things. I love hearing about all the things you're doing. So really, really exciting stuff. And I hope everyone in the audience is really listening to you, because that is going to be the future, these new models of care and how we essentially eliminate some of this documentation. I think that goes back to Julie, I don't know if you're probably younger than me, the old days of paper where if you didn't document, you didn't do it, which was kind of the paper, our paper mentality. And we kind of pulled that through, unfortunately, I think, with some of our uses of electronic documentation. So great stuff, Julie. We'll talk offline. That was phenomenal. Leo, I want to come back to you because I feel like we've been waiting for you for a while, and I know you have a lot to say. And I'm really excited to talk to you about this, really, because we talked about you had significant supply chain issues. And I know that you have some really good thoughts on how we can make these improvements and how we should leverage these lessons learned through COVID.
Sure, and thank you. So we did, and I mean, across the globe, everyone was going after the same set of supplies. What was also unfortunate, and it kind of touches on what Sean shared before, is that the level of consumption increased dramatically. I mean, Julie, you talked about your telehealth visits and how they popped from one day to the next. That's one example of infrastructure that needed to be put in place in order to be able to support those types of services. For us, the mask utilization, we used to consume 4,000 masks per day. And at the peak of the pandemic, we went up to 100,000 masks per day. I remember receiving a shipment of 500,000 masks and being super happy, reaching out to my colleague who runs the supply chain and saying, yes, we're good. And he started laughing because it was the only thing that you could do at that time. I said, Leo, like that's 5 days worth of masks. So when you think about the level of consumption, it is very difficult to truly prepare for something like that. What we have done in our organization is that we actually have stockpiled 3 months worth of supplies. It's important to recognize that that could also be considered hoarding. And so in our scenario, we happen to be fairly well funded. That means basically we consume the supplies. Yeah.
3 months supply based on what level? 1,000, 100,000, or somewhere in between?
Somewhere in between. That's a
good question. Now we know
yeah.
who to call.
No, Bob, that is a very, very good point. There's a cost to also sustain those supplies, and you have to think about what is the likelihood that we will ever get to that point. And so what we worked out is beyond just maintaining the stockpile, making sure, and we were just called out for this in a very interesting conversation this past week, making sure that is not perceived as hoarding. We also worked on processes, policies, and procedures in order to ramp up quickly. As part of the problem that we had wasn't just that the supplies weren't available, the processes weren't there, the policies weren't there. And so we created what, and I'm sure everyone's familiar, healthcare incident command structure, where at the time during the peak of the pandemic and through a number of months after, we were meeting every single day. There was representation from finance, from infection control, clinical leadership, operational leadership, IT, data, supply chain, and every single day we would talk about our situation that was at that time. When we start to see things spike up again, we pull that team together. We still meet once a week to make sure that everyone remains relevant to what's been going on. When we see things begin to spike, we bring it to 3 times a week, make sure that everyone's communicating, all the teams are communicating so that nothing is lost in the translation. So that will help us whenever something like this were to happen, be able to respond quicker. How we look at the infrastructure, and Sean again touched on this briefly, we essentially close the hospital and turn our ORs into ICUs, turn any room that could become an ICU an ICU. We're a 400 ICU bed organization. Within 6 weeks, we went up to 960 ICUs. Now, what's interesting, and when we were chatting prior to this event, Julie, I think it was you who called it out, we built 30 ICUs overnight. We literally met on a Sunday morning. By Monday morning, we had 30 ICU beds built into our ORs. In the past, it would take us an entire year to build 9. And we did it overnight. And so one of the jokes that was made, again, I think it was you, it's like we no longer have an excuse to take our time to build anything or come up with any solutions. But that was a fairly drastic situation that we found ourselves in. In the end, for us, as an organization, we ended up losing $1.6 billion. Fortunately, a lot of that money came back. And so ultimately, after the CARES Act and FEMA and all the support that we received from the federal government, we were able to only lose roughly $700 million. It's a lot of money, but for an organization that it was used to making, 3, 4, 5% margins. So essentially, somewhere between $200 to $300 million a year, going down 700, we essentially feel like our budget went down $1 billion. So we don't expect that we will be receiving that level of support. So we came up with lower cost models to be able to ramp up far quicker.
I just want to add something about what Sean talked about and having to create more beds. So it's really simple. You can bring a patient up on a stretcher and say, okay, I got the patient here. Great. But if you don't have the location that patient is in your electronic health record, you're not going to be able to admit them. You're not going to have documentation. You're not going to have orders. You're not going to have clinical decision support alerts saying, hey, this patient may be septic, or, this is where you bring the food tray if they can eat, and this is where you deliver the supplies, which means IT has to rapidly build all of this. And there's a lot of steps in it, and it does take time, and make sure you don't miss anything. But then there's also the revenue cycle part of it that, oh, wait a minute, is this a legal bed that we can buy? Is this a legal ICU bed? We're only certified for so many ICU beds. So it's really complex. And I am just amazed at how not just our clinicians managed it, because we used to get excited. We were like, oh, we have 436 patients, 396, we were good. Within 3 weeks, not even 3 weeks, it's, oh, we have 901 patients. And like everyone else, move the ED to a parking lot about 3/4 of a mile away. And you had to use ED beds, ambulatory surgery became beds, and kept expanding. Oh, now this is an area for beds, which is really great for the clinical folks. But then the IT folks are like, okay, we got to stand this up, and how do we do it? And, honestly, we had team members that were working 24/7, and maybe they weren't directly doing patient care, but they were doing patient care. And they may have been on the IT side, but what they did impacted our patients. And it was amazing to see how everybody came together to ensure we took care of our community.
Thanks, Julie. Sean, do you want to speak to that a little bit, Sean, and talk a little bit
I
about
wanna get
how we can?
reimbursed for the services we provide, right? So it's all about the documentation, making sure that we have the appropriate documentation, and even now we're getting hit with medical necessity denials, right? From our managed care payers. It's incredible, right? And even, knowing that there was a pandemic, managed care companies still, I guess, looking at the bottom line and make it very difficult to be reimbursed for the services you're providing. And I can just mention
Yeah, there's
that.
a lot of complexities to managing a hospital, right? It's not, I 100% think everyone realizes it's not just as easy as setting up a bed, putting a physical area there. Go ahead, Dr. Beverley, sorry.
About the medical necessity denials. So everybody talks about inappropriate admissions. I think there's a topic that we covered when we were at King's County, inappropriate denials. Okay, and when you send those cases to external appeal, Department of Finance external appeal, 44% of the cases were overturned. And the interesting thing, the health plan cannot appeal it. That's it. That's the final decision. 44%. And I'm wondering, if we were in a public hospital, would they be treating Mount Sinai and Columbia Presbyterian in the same way? So I think when we look at this inappropriate admission, let's add another inappropriate denials.
Right, and to add to that is there's the administrative component to that, which is a cost, right? That you have to add on to go out and fight these claims so you get reimbursed. Half of them are getting overturned.
Right. And we know on the clinician side, just trying to get someone who's denied, doing that process is very erroneous for them, right? That is a big complaint we hear from our clinical providers. They're trying to get their patients the healthcare they need. Dr. Beverley, you could probably speak to that a lot more intelligently than I can, but I do hear that from physicians. I'm a cardiologist. I'm talking to an internist. He doesn't even know what I'm asking for with this patient. He's telling me they're denied. Before we wrap up, I did just want to shout out to Dr. Beverley. She actually has written a article that's published Patient Engagement and Cultural Sensitivity as a Strategy to Improve Health Inequities. The solutions are as simple as they are complex. And I appreciate you sharing that with us, Dr. Beverley. And we'll make sure that everyone has access to the link so that they have the ability to be able to go out and read that if they're interested. Before we wrap up, I just wanted to turn it over to the panelists and see if they had any final thoughts to our topic of COVID before, during, and after I really can't say it's after because I'm the one sitting here with COVID. So I'll just say it exists. It's here. There is no after right now. It's sustaining. It's here. I have to learn to live with it like everybody else.
And
And
could I just ask a quick question?
sure, sure.
So just for this thing, how many have heard the word non-compliant? About 20 times, 2,000 times? Yeah, and now there's a nicer word, non-adherent, right? How many times have you heard why? Isn't that crazy? So we don't know why John Brown didn't take the medication, but we're going to refill the same prescription he didn't take and now call him non-compliant. And so I just want to only reason I just want to give a quick story because I think it's important to hear from the patient voices. So 60-year-old African-American male recently admitted for congestive heart failure, returns 2 weeks later, heart failure decompensated due to non-compliance. So my team had to ask why. They didn't ask why I was going to bug out, right? So we asked the patient, why don't you I can't take the water pill. Why can't you take the water pill? And I'm glad we're all sitting down. Guess what the answer was? I drive the number 7 train. So I can't take, so we brought in a cardiologist. When is your shift? My shift is from 11 p.m. to 11 a.m. What do you do when you get home? I do some chores, I make lunch, and I take a nap. But if I'm going to be on my shift, I don't take the water pill. So then the cardiologist said, okay, take the water pill when you get home. And be aware, it may wake you up during the day, but by the time you get to your shift, you'll have less of a reason to want to go to the bathroom. But to the degree that you do, I'm going to give you a cubicle so that you could use it in the private space. And you know what the patient said? If I knew I had to choose between peeing and breathing, I would have chosen breathing. And the interesting thing was, and the only reason I'm bringing this up because it talks about disparity and mortality. If this patient came back a couple of times to the hospital, and he might have actually passed and died at mortality report, when they report, they would have said, they would give the history and then said patient demise due to non-compliance. So I'm just want everybody to realize, if everybody in this room never heard the why questions, so there's something wrong within our system. And an article came out of University of Chicago that negativity in the medical records are more geared towards African Americans. Okay,
That's
so
amazing.
this
Thank
is
you
a
for that
simple
story.
solution to a problem, X, Y. If you don't know why I didn't do something, then you're going to blame me. And last thing I'm going to say on that, I can't prove it. There's no documents. I haven't read it anywhere, but I wouldn't be surprised if we caught patients non-compliant without asking why and turn those individuals into, quote, frequent flyers, because they have to maneuver the system all by themselves now.
Thank you, Dr. Beverley. That's insightful. I'll ask Sean, do you have any last thoughts?
I guess the only thing I would say, and just touching base on what Leo talked about, $700 million loss, we're not back, right? We're still struggling. Healthcare systems, hospitals, we're still struggling. We're seeing that either consumer or patient preference, that they're still avoiding coming back to the hospital. They prefer to be seen in an outpatient setting rather than the hospital. So we're not back, and there is no federal government funds to help support the organizations that are still struggling to retain and get back to normal or pre-normal levels. Like I mentioned earlier, I was at 11,000 discharges. I'm about at 8,000 now. I was at 279,000 visits annually. I'm about 230,000 visits. I had an ED visits about 50,000. I'm breaking 40,000 now. I'm still, about 12% off overall. And I think most health systems across the country are feeling that, and they're seeing that. And it's a struggle because, as I pointed out earlier, salary costs are going up, supply costs are going up, but the revenue's not there to support it. And it's making it very challenging.
Yeah,
health
I agree.
system.
And I'll add, and this is probably one of the next webinars, Tony, is that we trained our patients, our consumers, to go to CVS to get their COVID vaccination. So now they're going for other things as well, right? So they're not, maybe they have entered the hospital system for that in the past, and there's a whole generational thing going on there. Tony, that'll be another webinar in future. Leo, do you have any final thoughts?
Yeah, I have a more optimistic perspective than Sean. I do believe it does start fairly pessimistic. Healthcare processes were built over 100 years organically. We heard about the people that we have lost over the past 2-3 years. We lost generations worth of knowledge, generations worth of people that knew how to manage the processes within the hospital. So I expect that that will allow us to transform our respective organizations. It's going to take some time. It's going to be very, very painful, but at least we'll have clearer processes that don't have to be managed by the unicorns, the purple squirrels that we used to have running around making things happen unnecessarily.
Thanks. And Julie.
So I was just thinking about what you were talking about, and there is a loss of knowledge, and we do need that expertise. However, we're having access to a whole new set of ideas and innovation and asking why. Why do we do it this way? Well, because we always have done it this way. Well, why can't we do something different? And we really have to be open to different ideas and perspectives and listening. And I think that's the only way we're going to move forward, and listening to what our patients need, what our clinicians need, and help to support them. And then I'm just going to take a side note. First off, I want to thank Tony and Olga for having us here and organizing this, and my distinguished panel, Leo, I got it right this time, Dr. Beverley and Sean. And I really want to thank you for the courage you have to be here and to stand up and carry on your daughter's legacy. It's really beautiful.
That was wonderful. Thank you, Julie. I couldn't have ended it better in person. I appreciate all of you.
And I just want to say the parents and the kids are the strongest people I've ever met. So thank you.
Thank you.
Thanks, Julie. So I'll just wrap just briefly. Crisis is a catalyst for innovation. I don't believe it's after COVID. I think it's still before and during my own personal experience. I appreciate all of your time and attention and your tolerance in me being a talking head and joining from my home base in Baltimore. And next time I will be in person in New York City. So thank you all so much.
And thank you for controlling us.
Yes, thank you.
Oh, you guys are awesome. No control required. I prefer a panel where it's more conversational because I feel that's how the audience learns. And I didn't know, Tony, if you want to take a few minutes and just open it up to questions. I know we're between like cocktails and coffee, I think. So.
Well, I don't know if you can see this, but it's a certificate of appreciation. Your name is on it with your
Thanks,
picture.
Tony.
Okay?
Thank
Is
you.
that- Works good?
Thank you. Thank you. Appreciate that.
I'd like to not only thank you, but everybody on the panel, and we have this for everybody, to take your time out tonight. Now, I know it's getting late, so we could either take some questions or we can take some drinks. So why don't I see somebody hand up? One question? We'll do one question and then go.
And Leo, you kind of spoke to this, right? But healthcare is notorious for having silos up. Right down, right? Interdepartmental conversation on it. Now that we're, I think, backing away from COVID, you already alluded, right? Now your daily calls have gone to weekly. The other health system, you see the silos back up, or is that?
Well, I'll say no, thanks to Teams and Zoom meetings. There is no silos anymore. You can't hide. You know, that's what I'm seeing now. My experience right now, the pandemic has made us think out of the box and how we communicate with one another, and the innovation of the Zoom and the Teams meetings has really made an impact on how we communicate across the organization. Me personally, I feel like I sit in a Teams meeting from 8 a.m. to about 4 p.m. Because I think they don't even allow you to take a break in between, knowing that you're sitting at your desk, so that you can't even take a bio break. Right? You got another, back-to-back Teams meeting. We use Teams extensively.
You're in the perfect place for that.
Yeah.
Exactly.
So ladies and gentlemen, one other thing I'd like to point out. This meeting has been recorded on Teams. We will get the recording available. It'll be placed out onto the New York Hymns a YouTube page. It'll also be placed out on our website. Give us a couple of days. I'm sure HEC will also be able to pass the link around. Each of the sponsors that were here, I'd like to say one more thank you again. Okay,
If I could just make one comment, and thank you, everybody. This has been amazing panel, amazing discussion. I just want to leave with some memory recall. Martin Luther King, the Medical Committee for Health and Human Rights. Of all the forms of inequality, injustice in healthcare is the most shocking and humane. There's another statement by a hematologist, Dr. Zemsky. Difficult patients are not just born. They're in part created by the passage through the medical system. Not only has the system failed to cure, it may have done unpleasant things to make matters worse. The last one is from Hippocrates. It's better to know the individual